So today's session, today's keynote specifically is on the absorption, distribution, metabolism, and excretion of drugs, otherwise called the pharmacokinetics of drugs. And that's the abbreviation there, and how we think about those ideas in drug discovery. Okay, and so as we might know that once we have a compound that is active at target level or at cellular level, the big question becomes, if we're adding a compound to a test tube, then that's okay. We have whatever media we have in the test tube containing our cells, we add the compound, and provided the compound can get across whichever cells or whatever membranes we have available, the compound is going to get to the target. In an in vivo system, though, in an organism or in a whole human being, the situation tends to be more complicated. And that is because if you take a tablet, for example, unless you're taking a tablet to, I don't know, kill intestinal worms or something, the main reason you're taking the tablet is to work on a target or on an organism or on something that is inside your body. And so we need to think about a few more things in that situation. And that is, as just mentioned on the first day, we need to think about how is our compound going to get absorbed. And by that we mean, how will the compound move from being a tablet that we've swallowed to getting the bloodstream. Are we going to get enough of it in the system, or is it just going to pass through our system without interacting or without getting the blood at all? Then once the compound gets into the bloodstream, we need to think about how it's going to be distributed. And by that we mean, if we have malaria, for example, we want the compound to be in blood. But if you have TB, we know TB, there is maybe a little bit in blood, but we need the drug to get to the lungs, for example. So we need to think about how much of that compound we have in blood is going to get to the lungs, is going to get to whichever other target organs we're thinking about, and that's distribution. And of course, anytime we have a foreign compound in the body, that is an exogenous compound, a compound that is not part of our body's normal metabolism, the body treats it as a foreign thing, as something that needs to be gotten rid of. And so the other thing we need to think about is the metabolism of the compound. So how will the compound be broken down by the enzymes present in the body, especially in the liver? And what will result, how will that result in, or how will that impact our activity? If we have an active compound and we are metabolizing it and converting it to something that is not active, then it means that our activity is reducing over time. On the other hand, if we have an active compound and an active metabolite, then we are maintaining our activity over time or changing it slightly depending on the ratios of the rate of formation and the ratios of activity, or the activity of the parent compound and activity of the metabolite. And then at the end of the day, we have to think about how the compound is going to leave the body, because if you have malaria today, you are not going to have the same malaria infection 1 year from now if the drugs are working the way they should. So we need to make sure that once the drug has done whatever we need it to do, it has a way to leave the body, and that's excretion. And these are the questions that we need to think about anytime we're thinking about any drugs that are eventually intended for human use or for use in any other multicellular organism. That is, how will the compound get where it needs to get? That's the absorption. How is it going to be distributed? How is it going to be metabolized? And then finally, how is it going to leave the system? That's excretion. And the sum of all these questions, if we can answer them, provides us an answer on how is the compound, the ultimate question we're trying to answer is, at what can the compound get to the site of action that we need it to get to, and can it stay there for a long enough time to produce the biological activity that we're thinking about? So there are many different things that we need to think about to answer those questions. The very first of those is solubility. And the reason we think about solubility first is that from an in vitro perspective, for example, we need our compounds to be soluble if they are going to give us biological activity. So if we are screening molecules for cytotoxicity, for example, we need those compounds to be soluble in order to produce the cytotoxicity. So if I only have a solubility of 10 micromolar, for example, and I report that my compound is not cytotoxic at all, it may well be that it is not cytotoxic, but it's also possible that it's not cytotoxic because not enough of the compound is dissolving in the system to give me the effect that I'm looking for. The flip side of that is in an in vivo situation, if we're taking a tablet, for example, obviously we're not going to have a full tablet get into the bloodstream. So it will need to break down into something, and then the pieces that it's broken down into will need to dissolve in the gastrointestinal fluids, and then that solution form is what is ultimately going to be absorbed. And so solubility tends to be one of the most important things that we think about in drug discovery. And the earlier we think about it and the more accessible the solutions are early on, the easier the process is going to be as we go deeper into drug discovery. And so the way we measure solubility depends on the question we are trying to answer. If we're trying to answer whether the compound is soluble enough for biological assays, those of you who've done biological assays will know that you start from a stock solution in DMSO or in whatever other solvent your compound dissolves in, and you add that stock solution to the buffer or medium in which your cells, which contains your cells. And so what you're trying to answer from the solubility experiment is this, if I add my stock solution to the buffer or media that contains my cells, is the compound going to be soluble enough to give me the activity that I'm looking for? And measurements that employ that principle, that is starting from starting from a stock solution, a liquid stock solution, and adding that to buffer to result in a measurement called kinetic solubility methods. As you'd expect, that's those tend to be what we want to use, or tend to be the most commonly used early on in drug discovery, because we can prepare lots of DMSO stocks, we can screen many of them in parallel, and we can get some initial data that tries to address some of the questions we're thinking about. Ultimately, of course, we don't just want our compound to be soluble in the biological media and to confirm, to give us a confirmation of activity or cytotoxicity or whatever being measured. We ultimately want the compound to be soluble enough that when we go in vivo, the compound is going to get into a solution enough within the gastrointestinal tract that it's going to get absorbed. And so at the end of the day, what we will want to get to, even if we start with kinetic solubility, what we want to get to is how soluble is the solid form of the compound. And those measurements are broadly referred to as thermodynamic solubility. And this is important to know because even when working with data, for example, building a model, we need to recognize that there are differences in the way this data is acquired that might lead to differences in the values that we see. So a compound might look a little bit soluble when it's in DMSO stock, when we add a DMSO stock to buffer, because there is a small contribution of the DMSO, for example, and that gives us a falsely high solubility. But when we actually add the solid form of the compound to buffer, then we realize that it might not be as soluble as we thought it was. For the chemists among us, we also know that if we are measuring the solubility of a solid form in a liquid solution, then the form of that solid then starts to play a role. So is my compound amorphous? Is it crystalline? If it's crystalline, what crystalline form is it? Am I sure that every time I synthesize the compound, I'll get the same amorphous form or the same crystalline form? Because if I measure the solubility of a solid form, then that might change the next time I do my synthesis and produce another batch of compound, because thermodynamic solubility is will essentially involve the solid form of the compound breaking down and going into solution in water. So that's something to think about, and that is why, generally speaking, thermodynamic solubility tends to be more useful a bit later in drug discovery, when we've started getting an understanding of what our solid forms look like, and much later in drug discovery. So when we get to, for example, first in human trials, it becomes very important to even determine the solid form of the compound when we are starting the experiment, and to look at the solid form of the compound when we are finishing the experiment, such that we are completely sure that the solubility we're measuring is of a defined crystalline form in a defined way that gives us a specific solubility. You have a question?
Yeah. So what does the pH matter? Like pH, especially the 6.5 or 7.4? Because is it specific? Because I had a compound measured at 6.5, and I was later advised that I can do them at 7.4.
So
at what stage? Like, yeah.
The pH at which we measure solubility is, of course, quite important, as you'd expect from most drug-like compounds will have an ionizable group, and that will mean that the solubility is going to change depending on the pH at which we are measuring solubility. So for most of drug discovery, it tends to be most useful to measure either at the 6.5 or at the 7.4. The reason we want to measure the 7.4 is because a lot of the biological experiments we're going to perform are going to be at 7.4, for example, or close to that. But the flip side of that is that for the compound to be absorbed within the gastrointestinal tract, we are probably speaking about the compound being more soluble at a pH around 6.5 or 6.7, depending on the acidity of the drug. So whichever way we measure solubility is okay, provided within a specific project, provided we keep things consistent and compare results at 6.5 to other results at pH 6.5, or results at pH 7.4 versus other results at pH 7.4. The ultimate aim by the time we get into human clinical trials, for example, is that we will need to measure pH at all the physiologically relevant pH levels. So we'll need to measure what the solubility of the compound is under acidic conditions, so that we know what happens in the stomach. Then we'll need to know the solubility of the compound around pH 4 or 5, so that we know what happens in the early part of the small intestine. Then we'll need to know the solubility around pH 6.5 to 7 to know what happens in the mid part of the small intestines. And then we'll need to know solubility at pH 7.4, because we'll want to know how the compound is going to exist when it eventually gets into it. So ultimately, solubility across the pH range is important, but to start with, early on, it might be good enough to simply work at one pH level and compare values. Okay, so solubility, as we've said, is quite important, and one illustration of the importance is these comments that you tend to see once compounds start getting into clinical trials. So I've gotten this from the clinical study of MMV 390048, which was a compound developed at our Drug Discovery and Development Center with, of course, collaboration from MMV and others. And from the clinical study, you can see, and this compound is known to have low solubility. And from the clinical study, you can see the types of things that they started observing. They say they saw considerable inter-subject variability. And the reason we are getting variability is because this, my stomach pH might not be the same as your stomach pH, might not be the same as the stomach pH of someone who makes breakfast this morning. So depending on if your compound is, let's say, more soluble at a lower pH, then if someone has lower pH of someone else has higher pH, then the solubility of the compound is going to be different, and that's going to mean that different amounts of compound are absorbed and things like that. And then what you might also end up with as part of the individual variability is that you might end up with disproportionately high exposure with respect to other doses. What that means is that we don't see a good relationship between the dose of the compound that we give and the amount of compound that is absorbed. Because again, the same way there is inter-individual variability in pH, there is also intra-individual variability in pH in stomach and small intestine pH. That means that today, if I've eaten a very high protein meal for breakfast, my stomach pH for the next few hours is going to be a little bit different to someone who just took tea or coffee only, versus someone who just took carbohydrate-heavy breakfast. And that is going to mean that even within the same person taking the same medicine across different days, the data is going to be difficult to understand. And then this is a PK study for another antimalarial compound called alofantrin. And again, you see things about slow absorption. Then, just as we say, bioavailability is not dose dependent. Absorption is incomplete or erratic. No relationship between the dose and Cmax. Basil will be speaking about Cmax in a while. And then large inter-individual variability. Of course, you'll note that these compounds did actually make it to clinical studies. So as we'll keep on discussing, this saying that we have a compound with poor solubility, there might be reason to discard it completely, but if there are other things that speak to the compound and demonstrate how good the compound is, then there may still be ways to rescue it, but of course, that will be more expensive and more time-consuming rescue process. So something that we do need to do. Yes.
So as we using formulation chemistry, we can improve the solution. But how this type of chemistry can impact the DNT? And if it impacts DNT, then which stage of drug discovery you would recommend?
So the question is on the impact of formulation chemistry on rescuing drugs, essentially through the drug discovery process. There is, of course, a lot that you can do in terms of formulation, and a lot of those activities tend to be done around the design of the first-in-man trials, or the beginning of the clinical trial process. The problem is that exactly as you have with some of these compounds, the process is not guaranteed to give you a result. There are compounds that will be night and day between the initial formulation and the optimized formulation. There are other compounds that will still struggle with that. And then the other thing, remember, is that, as we will see in a little bit, is that the margins we need for solubility tend to be quite high. So a formulation that improves your solubility twofold or threefold might not give you a sufficient boost in solubility to move away from these variability issues, especially if the compound is poorly soluble. In most cases, you will find that you need a 10 or 100-fold improvement in solubility to get to the correct range that you need to be, especially for really poorly soluble compounds. And so formulations will help up to a point, but at the end of the day, if there is anything we can do in the design of the compound to factor in solubility, then that's always better, and it will save you a lot of time in having to do formulation screening at the end of the process. So at the beginning, we said that we have to think about how our compounds are going to cross membranes, starting first, of course, from the membranes in the gastrointestinal tract, moving to the different cell membranes of the different organisms that we are targeting in these drugs. And so permeability in general is a really important concept to think about for our compounds. And so in thinking about permeability, what we need to think about is how compounds actually cross biological membranes. And I know the biologists here will know much more about this, but the the summary point or the key point in permeability is that the easiest way and the most predictable way and the way that we want to target when we are designing drugs is to try as much as possible to make sure that our drugs can cross cell membranes through passive diffusion. Passive diffusion, as you recall, is a concentration gradient driven process. That means that when you first swallow your tablet and it dissolves within the gut, we have a high concentration on the gut side of the cells, and we have a lower concentration in blood. And so compound will move from where it's more highly concentrated passively through the membranes to blood. And because blood keeps on circulating, then we'll never, in most cases, we are not going to saturate the blood. So we'll essentially maintain a concentration gradient that allows us to keep on absorbing the compound. And the reason we need to think about that is that passive diffusion does not need us to think about anything else. If our compounds have very high passive diffusion, we don't have to think about whether they are subject of efflux or efflux transporters, because if the compound is efflux and it has high passive permeability, then it's just going to cross the membrane again. And provided the passive process is fast enough, then at a certain point, the concentrations are going to build up to a high enough level that you go above the maximum capacity of the transporter, so that even if our compound is being pumped out of the cell, we might still accumulate enough of it to give us activity. The next way, of course, compounds move, now that we've mentioned transporters, is through influx transport. That's endocytosis-driven process. So the compound binds to one side of the membrane, and then the cell configuration changes slightly, and that allows the compound to go through the membrane. And at the end of the day, that process relies on the compound binding on a specific transporter. So what that means is that we might have to design the compound. If we want to take advantage of that, we might have to design the compound in such a way of using structural features that help us to maximize the interaction with the transporter. And of course, that gets into competition with whatever we need to design so that we have better solubility, for example, or better overall activity. So high passive permeability is quite important for the drug that we're making. The way we measure passive permeability changes and evolves as we go across the drug discovery process. Very early on, or the most basic way to measure this is to have an artificial membrane. We know the materials that make up the cell membrane, so we can either use those materials or mimic them sufficiently in an assay called the parallel artificial membrane assay that allows us to essentially measure the flux of compound from a buffer side through that artificial membrane to another side, and then essentially measure the rate of passage of the compound. That's the most basic and probably most high throughput way to perform the measurement. Later on, we might want to think about using cells, so using what we call the kappa-2 cell line, the MDCK, and many other cell lines. And essentially, what we're trying to do here is, with the kappa-2, for example, is a colon carcinoma-derived cell line. So we are trying to measure the passage of the compound across an actual cell membrane, and then find ways, once we have the permeability measurement, to translate those values to an in vivo setting. If we want to be really, really complicated, then we can try ex vivo models. That's where we essentially introduce the compound on one side of an experimental model, allow the compound to go through the gut, and then measure either the amount of compound making it into blood or the amount of compound at the far part of the small intestine. And essentially just subtract the two to say this percent of compound has gotten absorbed. For the most part, in routine drug discovery, you tend to have almost all the information you need from APA2 and from the parallel artificial membrane assay. And it's only in rare instances that you need to think about ex vivo models. It would usually be if there is if the data does not make sense. If you have really high APA2 permeability, for example, but for whatever reason your bioavailability is just not there. Yes.
For the choice of the cell lines to use, besides availability and cost, is there any criteria to use to say I've tested in APA2 of MBCA, the other is it just by virtue of their availability, or is there a cost element, or is there any physiologically relevant guide to say this data was by this cell, so it's more reliable than the other, or should we use at least two of the cell lines like the way we normally do for sector toxicity?
Thankfully, for most of these cell lines, because all we are measuring is how quickly our compound can go through a cell membrane, and assuming that the compound is primarily going through the membrane through passive diffusion, cell membranes are the same all over the body, so the data tends to be maybe not similar as such, but it tends to move in the same direction. So if you have 10 compounds, the compound with the highest permeability in the APA2 cell line will be the highest permeability in the MPCK cell line, and will have the highest permeability in the HEK cell line as well, and the reverse is true as well. There is a slight difference in transporter expression across the cell lines, and so if a compound relies on transporter-mediated absorption of transporter-mediated passive membranes, there are slight differences in the cell lines that are going to give you different data. But in the early part of drug discovery, say going all the way to lead optimization or even late lead optimization, the key question we are trying to answer is what is how quickly the compound goes across the membrane through using passive diffusion. And the questions on whether this transporter here is impacting this compound and not this compound would tend to only be relevant first if the compound really needs to rely on transporters, or if not, much later on in the discovery process. So whatever is available should give you data that tracks across this. Yes.
But just a follow-up to this question. There is the blood-brain barrier, which has to be when it comes to that, which cell line flows via the chemicals, it's much more favorable than if you have the brain, some people much more likely to stay alive.
So the blood-brain barrier tends to be a more complicated topic because access through the blood-brain barrier is not just through passive diffusion. And even when drugs go across passive diffusion, our brains or our nervous systems have built up remarkable mechanism to essentially pump out compounds to avoid accumulation in the brain, essentially because the body does not want or is trying to make sure that you don't affect what is a really critical system. So permeability across the blood-brain barrier tends to be a little bit more difficult to measure across these cell lines, and sometimes whether a compound is a substrate for a transporter or not might be more important in whether it can accumulate in the brain versus not accumulate in the brain. You find compounds with really high passive permeability values that don't access the brain at all, or access the brain and are very quickly pumped out. So that tends to be a bit tricky to measure.
Which people always take you to use one of your compound outside that. So is it which people always use to be able to compound outside of this?
Okay. So the method we use to measure the compound passage is just LCMS. So if you can picture this, I think I removed the picture from here, but if we use this as an example, we are adding the compound to the top part of the compartment. We have a membrane in between, and we are measuring the amount of compound that makes it through into this buffer. And we can simply measure the concentration. We know the concentration we added. The concentration of this at time 0 was 0. So we can measure the concentration there, and by factoring in the amount of compound we added and the area of the membrane, we can factor in how quickly the compound is moving per unit of membrane.
Any question will
We'll talk about thresholds and cutoffs in the skills activity, where we'll be looking at some DMPK data. But in general, you want your compounds to be as permeable as possible. We'll talk about examples of some values.
So it's the transporters today, so let's say active transport level. This is the passive conclusion.
Yes, so you can have transport either into the cell, influx transporters, or you can have transport outside the cell. That's efflux transporters.
The rate of these two, I guess that depends on the number of things.
It depends on the compound. So remember again, the ideal compound, the ideal drug discovery compound is not a substrate to any of these transporters. We want to rely only on passive diffusion to accumulate as much compound as we need where we need. And then yesterday there was a question of how soluble a compound needs to be, and we can extend it to how permeable a compound needs to be. And at the end of the day, there is an equation that links, or there is a relationship between solubility, the solubility of a compound and its permeability that I have here. You can read more details here, but in general, as you might imagine, if we picture the compound in the gut, if a compound is really soluble, then we can afford to bring the bar a little bit down in terms of permeability. And if the compound is extremely permeable, then we can probably get away with a little less solubility. But in general, the solubility that we need to make sure that we do not have any issues in a drug discovery setting, as you realize, tends to be quite high. So if we think as a quick note on about TB drugs, for example, which tend to be dosed around 10 milligrams per kilogram, then the solubility that we will need for a compound with low permeability approaches 100 micrograms per ml, as an example. So that allows you to start thinking about how permeable you need your compound to be, if you are, or how soluble you want your compound to be, if you want to say you have high solubility in that context. I'll very quickly mention two concepts that are also important in thinking about all this, and they tend to relate mostly to permeability, to how quickly the compound goes across the membrane. And those concepts are lipophilicity and pKa. Lipophilicity, as we know, is a measure of how the compound partitions between an aqueous layer and a non-aqueous layer, or between a polar layer and a non-polar layer. Most commonly, we measure lipophilicity across water and octanol, or you would measure it across water and octanol, but because most compounds we use in drug discovery have a weakly basic character, then we have to think about how the ionization of those compounds is going to change how they distribute between aqueous layers and non-aqueous layers. So, as an example, if we have a drug, for example, that we add into buffer and it ionizes, only or mostly the non-ionized drug is going to distribute in the octanol, and anything that ionizes is going to remain within the buffer layer. And so when we think about lipophilicity in drug discovery, it's sometimes more useful to think about it in terms of the log D of the compound, which represents the lipophilicity measured accounting for ionizable compound, than to think about the log P of the compound, which just thinks about the raw distribution of the compound without factoring in ionization. like with other drug discovery properties, there tends to be a happy middle somewhere around the log this of 1 and 3, where we tend to have a good balance of properties. Because highly lipophilic compounds, if you picture what we are saying with this, the octanol vein, you can think about it as your lipophilic vein. You can think about it as your cell membrane, for example. So a highly lipophilic compound means that a lot of it will make it to blood layer. And in a similar way, you expect a lot of compounds to make it into the membrane. Of course, if the lipophilicity is too high, then your compound will get into the membrane, but will not go across the membrane to the other side, to the other layer, to the blood side, for example. So that we tend to need a happy medium somewhere between having a compound that is lipophilic enough to get into the membrane, but also not so high that it gets into the membrane and just remains within the membrane and does not go across that into our cytoplasm. Okay, and then very quickly moving on to drug metabolism, because we say for most drugs that we take, they interact one way or other with the drug metabolizing enzymes that we have in the liver. And that interaction tends to result in a transformation that can either be a redox type of reaction, what most people refer to as phase 1 metabolism, and an additional way is a conjugative type of transformation, that is attaching an endogenous molecule to our compounds, and that tends to be called, or is usually referred to as phase 2 metabolism. Phase 1 and 2 refer more to the types of metabolism that occur rather than to the stages, or rather than to the sequence in which they occur. So you can have phase 1 metabolism occurring before phase 2 metabolism, phase 2 metabolism followed by phase 1 metabolism, followed by phase 2 metabolism, and you can have many variations of that. And the only thing is that the compound is going to be metabolized until it has the right properties to be excreted from the body. Usually, metabolism will be a process of increasing the polarity of the compound so that it's so polar that it can no longer, it loses its passive diffusion ability essentially, and can no longer get reabsorbed once it's excreted from the body. And so phase 1 and 2 will essentially take place for the compound until the compound is polar enough or transformed enough to be excreted. How we measure metabolism tends to rely on where metabolism takes place. Most metabolism, as we know, takes place within the liver, and the cells inside the liver are called hepatocytes. So the most natural way to measure metabolism would be to say, get some hepatocytes, add in our compound, and then see what happens over a certain period of time. But of course, getting hepatocytes, that is intact cells from a whole human liver, is a complicated process. So if you do it yourself, of course, it's complicated. If somebody else does it for you, then there is a cost element as well. So it tends to be the lower throughput assay and the more expensive assay to perform. A small shortcut to that is using microsomes. And microsomes are essentially ground up portions of the liver. So we start from the liver, we grind it down into a paste, we centrifuge it and extract out the portion that contains the drug metabolizing enzymes that we're interested in. And depending on what we want to study, there are many different fractions we can use, but microsomes tend to be the most relevant in the drug discovery setting. And that's because they contain most of the cytochrome P450 enzymes that mediate the redox metabolism that constitutes most of the metabolism that drugs do. And then the way we think about metabolism data tends to change depending on first what we are using the data for, and then depending on how we want to think about our data. And what that means is that the very first time when we do a metabolism experiment, we have an amount of compound that we've added into the system. We allow metabolism to take place, and we can measure the amount of compound that is left after the experiment has taken place. So the primary data that we are going to get from the experiment is percentage remaining. So we can say there is 10% compound remaining or 90% compound. Of course, for us to a high percent remaining is better than a low percent remaining, because if I say 90% remaining, I mean after all the metabolism has taken place, I still have 90% of my compound intact and unchanged. So having a high percent remaining is good, having a low percent remaining not so good. From percent remaining, we can also think about how long it is taking our compound to be broken down. So we can think about the half-life of the breakdown of the compound. So as you can picture it, having a really long half-life means that my compound takes a long time to get broken down. So that means that's good for me, because I want as much of my compound to remain as possible. Having a short half-life, not so good. From half-life, we can think about the clearance of the compound, and that is how much of my compound is being lost per unit of time, per unit of system that I'm using. So per unit of microsomes or per unit of hepatocytes that I'm using. And again, if we think about clearance, we're measuring how much compound is being lost. So I want a small number. I want as little of my compound as possible to be removed from the system, so that I have a high amount of compound left. So having a high percent remaining translates to having a long half-life, translates to having a low clearance value. And then finally, once I have that data, I can think about, I've measured this in 1 million hepatocytes, for example. I know the number of hepatocytes that I can get from 1 gram of liver. I know how many grams of liver there are per kilogram of body weight. So I can translate the value that I have in vitro to an in vivo value. I don't want to go too much into the calculations, but I hope that captures the general concept of the values. So a good compound has a high percent remaining, has a long half-life, has a low clearance, and has a low predicted clearance. Yes,
that's very helpful. So that means that we're incubating the compounds to establish their in vitro metabolic stability among the information you have to remember is how much of the microsomes.
Yeah, yes, but now here is where we need to think about the different ways of measuring, because if I say, or if I read in a paper that the authors investigated metabolism of a compound and found there was 90% remaining, then I'm missing a lot of information from that, because I don't know how long the experiment was performed for. As you can imagine, if I have 90% remaining after a 1 minute incubation, that's not as impressive. If I have 90% remaining after 60 minute incubation, then that's something interesting. And then I also don't know exactly, as you mentioned, how much microsomal protein I have, or how many hepatocytes I'm using. Of course, if I use a high number of hepatocytes and still end up with a high percent remaining, then that's good. If I use a really low number of hepatocytes and still see a lot of metabolism, which means a low percent remaining, that's not so good. So that's the limitation of using percent remaining. If on the other hand, I use half-life to report data, then half-life at least solves the time delay, because if I have the correct amount of data, whether I do my experiment for 10 minutes or for 60 minutes, does not matter, because I expect the half-life to be consistent because once I transform the data. Clearance, on the other hand, as you'll notice, we are looking at clearance in terms of the microliters of the incubation that I performed, per minute of time that I used, per milligram of microsomal protein that I used. So with all factors remaining constant, in most cases, it should not matter whether I did the experiment for 10 minutes or for 60 minutes, should not matter whether I used 0.1 milligram per ml of microsomal protein or 0.5 milligram per ml of microsomal protein, because the unit should cancel out and should give me values that are generally comparable. Lisa will, of course, be speaking about unbound compound, and that might tend to skew your values a little bit, but in general, using clearance allows you or gives you a value that you can compare across it. Yes.
But, two questions. About getting the hepatocytes from the liver, why not use?
That is because, his question is why we use hepatocytes from the liver rather than from cultured cell lines like HepG2. And the reason for that is that as we culture cell lines, we lose enzyme activity. For many different reasons, the enzyme activity that we have in the liver needs the liver to be within the body, because the enzyme activity is maintained by signaling pathways that essentially need all the cells in the liver, even the cells that contribute to just connective tissue within the liver. So you tend to get much higher activity if you have either fresh hepatocytes or if you have fresh hepatocytes but preserved in a media that allows us to store them in liquid nitrogen. That's essentially the 100% mark, and by the time you get into the HepG2 cell line, you might be at the 30% mark in terms of how active the enzymes are. And the other bit, of course, you could say, why not just do the measurement and multiply the value by 3? But the problem is that the enzymes do not change at the same rate. Some enzymes in HepG2 cell lines decay or break down much faster than others, such that if your compound is metabolized by an enzyme that is highly present in the HepG2 cell line, you will say that the compound is getting very rapidly metabolized. But if it's metabolized by an enzyme that is almost absent in HepG2, then you won't see any metabolism. Oh, sorry. Yes.
I was saying, considering that the hepatocytes can metabolize compounds, what's the course in terms of the cyclic dose? That does not give the false results, because in the case the hepatocyte is going to metabolize the compounds, suppose it's very easy, that might give you toxin.
So this tends to depend on what question we are trying to answer. So if we are trying to answer, is my compound cytotoxic or not, then we don't want it to be metabolized. But there might be reasons to think that the metabolite of the compound is the one that is cytotoxic, in which case I want a cytotoxicity system that breaks down my compound to that metabolite and allows me to say my metabolite is not cytotoxic. So it depends on the question we want to answer. Early on in drug discovery, it's probably easiest for structure activity relationship if I can say my compound is not active. And then later on, we can answer whether my metabolite is active once we know what metabolite is in.
Is there a way of, is there any correlation between metabolic stability using glyphosate and toxicity? What can you say we are now analyzing the toxicity?
The concentrations we use for metabolism experiments, especially, for example, in hepatocytes, tend to be low enough that in general toxicity is not going to affect the data that we see. If we do suspect that the compounds are extremely toxic and are essentially killing hepatocytes, then the microsomes might be a better idea, because the microsomes, as we say, we've ground up the liver and extracted out only the drug metabolizing enzymes. So in theory, we should be able to measure a value that only relies with how well a compound interacts with drug metabolizing enzymes, and whether it's toxic or not does not matter. So if it doesn't, so if we can measure the value, say in microsomes, then it doesn't matter. It should not affect any of the parameters, because it's just metabolism. I know we're starting to run short of time, so we'll just do one more thing, and then we can still answer the questions over the course of the day. So what I just want to do lastly is to link what we're talking about to what Lizon is going to talk about. And that is to say that at the end of the day, as we mentioned, we are trying to say how well is a compound going to get absorbed, and then how is that going to affect how it is distributed, how it is metabolized, and how it is excreted. So there is a way to essentially bring all our numbers together. And that is using this simple equation. And what the equation is the area under the curve, which Lizon is about to speak about, is a product of how much of my compound is going to get absorbed, and how much of the compound gets absorbed depends on the physicochemical properties of the compound, solubility, lipophilicity, permeability, ionization, and things like that. And then is also dependent on how much of the compound is metabolized within the gut. There are ways to measure that much later in drug discovery, but early on in drug discovery, the best surrogate tends to be the metabolic stability of the compound. And then finally, the biggest thing is what is my unbound intrinsic clearance, and that is, again, we get directly from our metabolic stability. And what we want to say generally as we transition now to PK is that the reason we are going to all this struggle to measure solubility of P and all these things is because there is a lot that we can do in vitro that already gives us an answer on what we expect to see in an in vivo.